Esophageal carcinoma is a PANCE favorite, but there are so many nuances to esophageal cancer that a lot of students get lost in the sauce and don't know what they should actually be focusing on. My name is Maruf, and in this video, I'll provide you with the most important details that you need to know about esophageal cancer so that you can feel comfortable on your boards. Let's dive right into it. The PANCE loves to ask questions about the two subtypes of esophageal cancer, squamous cell carcinoma and adenocarcinoma. Now, each of these histologic subtypes do have their own defining features, but they can feel pretty random at first and therefore pretty difficult to remember. To help you understand these two subtypes better, first we need to go over some basics. First of all, as we know, cancers occur due to genetic mutations that allow for this unregulated growth. But did you know that one of the most common ways to obtain a genetic mutation is actually just through chronic inflammation? That's exactly what you get in viral hepatitis, which leads to chronic inflammation of the liver, and then you ultimately can get liver cancer, or chronic inflammation with HPV, which can eventually lead to genital cancers, chronic inflammation from ulcerative colitis, which will eventually lead to things like colorectal cancer, and you can kind of just keep making analogies like this. In the upper esophagus, you're usually going to get this chronic state of inflammation from things like smoking tobacco, drinking alcohol, or drinking hot beverages like hot teas. All of these things are going to cause repeated bouts of injury and inflammation to the upper esophagus, and eventually that can lead to cancer formation. Now, these habits of smoking and drinking hot teas are pretty common in the Eastern world and South Africa, so we usually see that these cancers of the upper esophagus are more likely to occur in people from Asia or South Africa. Since the upper esophagus is mostly made of squamous epithelial cells, a cancer of the upper esophagus will primarily manifest as squamous cell carcinoma. Now, understanding this background information, it should make sense to you why esophageal squamous cell carcinoma will be associated with proximal esophageal lesions, which is where the squamous cells are, risk factors like smoking, alcohol use, or hot teas, and either an Asian or a South African descent where these habits are a little bit more common. Now, when we're talking about the lower esophagus, chronic inflammation is a lot more likely to occur from frequent acid exposure, like in patients with GERD or obesity, which makes GERD more likely. In general, GERD and obesity are much more common in America, so therefore we're going to be more likely to see lower esophageal cancers in patients from America as well. Now, sometimes the chronic acid exposure and damage can cause the lower esophageal epithelium to actually undergo a transformation, where they go from squamous epithelium to columnar epithelium instead, similar to the epithelium that you might see in the stomach or the intestines. Now, that is the classic pathology in Barrett's esophagus. Now, the columnar epithelium of Barrett's are technically more protective than the squamous epithelial cells that used to be there. The new epithelium now has glandular goblet cells, which are similar to the cells that we saw in the stomach, and they essentially create mucus to help line the esophagus against acid exposure. And again, this might sound like a good little worker taking initiative to be his better self. In reality, this metaplastic change will significantly increase the risk that these cells will undergo future genetic mutations down the line. And of course, that increases the risk of malignancy. Now, since these cells are glandular or adeno in nature, that prefix adeno literally means glandular, when these cells become cancerous, they develop into an esophageal adenocarcinoma. And this is why esophageal adenocarcinoma is seen in the lower esophagus, where the acid damage is more likely to cause cells to become glandular, is associated with risk factors like GERD, Barrett's esophagus, and obesity, all of these things which increase acid to that lower esophagus, and is more likely seen in North America, where obesity and GERD is just more prevalent. Now, patients with esophageal cancer, whether adeno or squamous cell carcinoma, will primarily manifest with difficulty swallowing as their chief complaint. Now, this will classically be described as a dysphagia to solids in early disease, but then it will eventually progress to the involvement of liquids as well when that mass gets larger and larger. And eventually, the inability to get food into the stomach will cause significant weight loss in these patients, although that's not a very specific thing for esophageal cancer. Now, one of the ways that the boards can trick you up is by making you think that every patient with dysphagia that progresses from solids to liquids has esophageal cancer. But you have to remember that Zenker diverticulum can also present with a pattern of dysphagia from solids to liquids, as well as even weight loss. That unfortunately makes it sound very similar to esophageal cancer. The key difference here is that in Zanker's diverticulum, you have this stork like pouch in the back of your throat that essentially holds on to undigested foods. That usually causes additional symptoms of things like bad breath and regurgitation. That's why, if you see symptoms of halitosis and regurgitation, you should think Zenker first and obtain a barium swallow as your first study. Take note here that this is completely different from what you would do otherwise if you have a patient coming in with progressive dysphagia of solids to liquids. Instead, if your patient has the classic pattern of dysphagia and they don't have Zanker symptoms, then you should presume that they have esophageal cancer until proven otherwise. And in that case, the next step should be to perform an upper endoscopy with biopsy. Now, an EGD with biopsy is your gold standard for the diagnosis of esophageal cancer because it will actually allow for you to directly visualize that cancerous lesion and also confirm those cancerous cells on actual histology. Now, these patients will eventually go on to have other studies like CAT scans, PET scans, and these are to help you get a better idea of the staging of the disease. But I find that disease staging is usually much more advanced than what the boards need you to know, and time is better spent elsewhere. Now, once you've confirmed the diagnosis of esophageal cancer by endoscopy with biopsy, the next step is to ideally offer curative intervention with either resection of the tumor and or chemoradiation. Now, when you're dealing with an early cancer where the tumor is localized to the inner walls of the esophagus, you're usually able to get away with just endoscopic intervention and resection. And that's it. They're pretty much cured. If you find that the patient has a little bit more local regional infiltration, for example, it's infiltrated to the nearby lymph nodes or to the pleura or whatnot, then usually you're going to do chemo and radiation first and then offer a surgical esophagectomy where you actually take out a good section of that esophagus that has those infiltrations with esophageal cancerous cells. Now, of course, if it's fairly late in disease, like advanced disease with metastasis to other locations in your body, then usually surgical interventions are no longer able to provide actual cure. And instead, you're going to provide mostly chemoradiation as a palliative measure to hopefully decrease some of the symptoms that the patient has from the tumor, but probably not cure them, unfortunately. Now, the management of esophageal cancer can get much more complex than this, but in reality, the PANCE doesn't really focus on those complexities like staging to determine the treatment of the cancer. So instead, I find it much more simplistic to think of it in this fashion, and ultimately, more than enough for what you need for the boards. Now, while esophageal cancer is going to be the most important cause of dysphagia, it certainly isn't the most common cause. In fact, diseases like GERD, eosinophilic esophagitis, achalasia, they can all present fairly similarly, so I definitely recommend that you check out those videos next. Otherwise, be on the lookout for my next video where I go over a nice, clean approach to how to tackle dysphagia on the boards so you never miss those questions again. I'll see you there.